topic that I want to introduce in this video that is related to gastroparesis is why should we even care about delayed gastric emptying time from a pharmacokinetic perspective. So we have discussed absorption a little bit in a few of the previous videos, and now we will revisit it here. But we do have to go back to our organic chemistry for just a moment. So the majority of drugs are either weak acids or they are weak bases. And this means that at all times in the body there will be a portion of ionized and a portion of unionized drug. And pH will dictate which drug form is present predominantly. And the important takeaway is that the unionized form will be the only form that can be absorbed. But remember, there's always going to be a portion of each present, and this equilibrium or sort of proportions will always be maintained. So in the stomach, the pH is low. So weak bases are mostly ionized because of all the protons. So there is little absorption of drug actually occurring in the stomach if we're talking about a weak base. But that is fine because once it travels to the small intestines, where it reaches a more basic environment, it will mostly be unionized, where it can be absorbed readily, and then more will continue to shift to being unionized, continue to be absorbed, and it'll be this sort of cyclical process, further propagating drug absorption. So moving on to weak acidic drugs. So weak acids are a little bit more complicated. Weak acids in the stomach are mostly unionized because of all the protons from the low pH of the stomach. Because this unionized form is the predominant species present, it should be readily absorbed in the stomach, right? Well, because the surface area of the stomach is so small, little absorption can actually occur in the stomach, regardless of ionization state. So even though some might get in, most will travel to the small intestines. But because the small intestine is more basic, most of the weak acid will actually be ionized and not readily absorbed. But remember, there is always some that is going to be unionized, even if it's only 1%. So that 1% will be absorbed, and this equilibrium will maintain this minute portion that is unionized to keep being absorbed, and so forth, further propagating drug absorption. And the reason this works, despite the pH of the small intestines, is because of the immense amount of surface area built into the specialized organ so that it is primed for absorption. And this would be all those folds, microvilli, villi, etc. that are found within the small intestine. So moving to the next slide. The takeaway here is chemistry will tell you weak acids should be absorbed in the stomach and weak bases should be absorbed in the small intestines. But because of the surface area, most drug absorption is going to occur in the small intestines regardless. So why does this matter for gastroparesis? So normally a drug will move from the stomach to the small intestines and be absorbed based on gastric emptying time. And under normal circumstances, this concentration time graph might look like this based on the rate of drug absorption, with, say, the therapeutic concentration being above this dotted line. But with delayed gastric emptying time, the movement of the drug to the small intestines to be absorbed is much slower. So this rate of absorption of the drug is going to be slowed. But it's not going to affect the extent of absorption, really, because it's all eventually going to hit that small intestines, and because of this increased surface area, we'll still be able to absorb the drug to the same extent, but if this rate is slowed enough, the plasma concentrations may actually never reach the concentration needed to be effective, even though the extent of absorption is the same. Conversely, if someone has gastroparesis and say you increase their dose of meds, for example, to hit this ideal therapeutic concentration, despite the delayed gastric emptying, might be what this curve looks like. But then let's say you decide to treat their gastroparesis with either a prokinetic agent, which will get things moving again, or you remove an offending agent that might be slowing down gastric emptying time. So if you do either of these two things, gastric emptying time will accelerate and will be pushing those contents of the stomach into the small intestine much more quickly to be absorbed. And this can lead to an increased rate of drug absorption from before, potentially causing a concentration spike that leads to toxic effects. But again, that extent of absorption isn't affected, just the rate of absorption. So the faster the drug gets in, the faster that concentration is going to spike, and vice versa. So gastric emptying time and agents that can influence this are very important to be aware of when it comes to patient education and counseling. But also, this relationship between gastric emptying time and drug absorption is not necessarily the most intuitive. So I wanted to introduce it early on so you can start becoming familiar with things that can affect drug absorption, because this is an important concept that will be revisited in pharmacology in Block 4.